Good morning, everybody. I can see people already joining in. We're going to give them others maybe 2 minutes or so, something like that, to also join us. Dr. Cobb, is that, I forgot to ask yesterday, is that your office or are you at home?
I'm at home.
Oh, yeah, okay.
I'm at home.
Yeah. I know Dr. White is in his office, and Dr. Trenchell, are you at home or are you in your office?
No, it's my office. Looks like a home, but it's my office.
They've become mini homes here.
They do. I spend more time here than I do at home. That's for sure.
Yes.
Yes. Oh, yes. Yes. The two
Our earlier
flags.
conversation, there's no way I would do this interview at home. Or kids ready to round.
Yeah. Yeah, if my kid comes waltzing in here, I told him not to, but
I loved it though. Every once in a while they need a little hug or something.
yeah. Good morning, folks. If you're just joining us, we're going to start in about 1 minute. We're going to allow others to also join us this morning. Yeah, that two flags that I have in the back, those are the flags that we got when my wife and I became citizens.
Oh, that's
Oh, how special.
Yeah.
Is that? Luigi, when did you become a citizen?
2012.
Oh.
Yeah.
Where'd you do your swearing in? Was it there in Phoenix?
It was at the Phoenix College. Is it the South Mountain College or is it the Phoenix College? I can't remember which one, but it was a big gymnasium. It was on July 4th, 2012.
Oh.
Yeah.
Special day.
What a special.
Yep. They actually asked me to speak.
moment.
Yeah. They also asked me to speak at the swearing in.
Yeah.
So that was special. All right. I think we're gonna start. All right, I think we are going to start. We've got a lot of people already joined us. Good morning, everybody, and thank you for joining us this morning. Welcome to the Arizona Capital Times Morning Scoop, Hospitals on the Front Line Against COVID-19. As you can imagine, we have a lot to talk about. My name is Luigi Del Puerto. I'm the associate publisher and editor of the Arizona Capital Times. The Arizona Capital Times, of course, covers state politics and state government. If you don't have a subscription, please do subscribe. Give that as a gift to yourself, and let me know so I can we can fix that problem, if you will. A lot of our subscribers and our readers refer to the Arizona Capital Times as an independent, nonpartisan, non-ideological newspaper, and I agree with that 100%. I also kind of like to refer to ourselves as an equal harassment newspaper. So I want to thank our sponsor this morning for engaging and supporting us in this way. Without their support, we would not be able to hold important discussions of subjects such as the one that we're discussing this morning. The Arizona Hospital and Healthcare Association is the statewide association giving Arizona hospitals a voice to collectively build better healthcare and health for Arizonans. The association and its member hospitals explore ideas and take collaborative action at the state capitol, in hospitals, and at home to attain the best healthcare outcomes for Arizonans. Again, thank you to the Arizona Hospital and Healthcare Association for sponsoring this morning's discussion. We have a great panel this morning. Joining us is Anne-Marie Alhamidin. I hope I got that pronunciation correct, who is the president and CEO of the Arizona Hospital and Healthcare Association. As president and CEO, Anne-Marie keeps her expertise with the needs of both Arizona hospitals and patients alike at the forefront of her work. With an extensive background in community service and organizing, she's well-versed in bringing people and organizations together, not only to exchange ideas, but to take affirmative action and achieve desired results in driving health policy. Anne-Marie, thank you again for joining us.
Thank you for having me.
Also joining us is Dr. Michael White, who is the Executive Vice President, Chief Medical Officer of ValueWise Health. In his role, Dr. White works to advance the mission, vision, and values of ValueWise Health to improve clinical outcomes, enhance patient experience, and grow key programs. He also serves as a liaison with partners at District Medical Group and the Creighton University Arizona Health Education Alliance. Prior to joining ValueWise Health, Dr. White served as Chief Academic Officer at CHI Health in Omaha, Nebraska, a nonprofit faith-based health system providing services in 18 states through 101 hospitals, including 3 academic health centers and major teaching hospitals. Dr. White also held the role of Associate Dean for Education and Innovation at Creighton University School of Medicine, also in Omaha, since 2015. He is a practicing interventional cardiologist. Dr. White, thanks for joining us.
Thank you for having us.
Also joining us this morning is Representative Regina Cobb. Dr. Regina Cobb chairs the House Appropriations Committee and is recognized as an expert on many issues, including healthcare. She has served in the Arizona House of Representatives for 6 years. She moved to Kingman after graduating from dental school in 1993. She raised 2 daughters in Kingman and is proud to be a part of the community. Having served as the president of the Kingman Chamber of Commerce and running her own small business, Representative Cobb understands the daily struggles of government regulation and the burden of overtaxation. Representative Cobb, thank you for joining us.
Thank you so much for having us.
And finally, we have Dr. Robert Tranchil, who is the president and CEO of the Yuma Regional Medical Center. Dr. Robert Bob Tranchil brings nearly 20 years of healthcare and medical management experience to Yuma Regional Medical Center. His strong focus on population health emphasizes the hospital's responsibility to utilize its resources in a way that benefits the overall health and well-being of the community and the region. Dr. Tranchil served as a physician in a private practice from 1990 to 2000. He graduated from medical school from Nova Southeastern University in Fort Lauderdale, Florida, and holds a master's of public health from Florida International University in Miami. Dr. Tranchil, thank you for joining us this morning.
Thank you for having us.
So one housekeeping note, please send in your questions. We will try to get to as many of them as we can this morning. I'm sure you have a lot of queries in your mind, as do I. So what happened, this is what happened since yesterday. Governor Doug Ducey gave cities and counties the power to require people to wear masks. And a big part of the reason is the spike in cases that we have seen over several days. And we'll go through some of the issues, many of the issues the hospitals are facing as they try to manage this pandemic. But I want to ask Representative Cobb, ma'am, where are we with a potential special session? Can you give us an update?
Well, we're getting a new update tomorrow from our financial advisors. So we will actually have a better idea of where we are in the state right now. But right now, I don't see a special session before July 1st. I don't think we have the numbers or the certainty to be able to go back into a special session. If we do, if we were to go back into a special session, I think we would be doing a 2 or 3 special session on the budget itself. So I think waiting and kind of getting a more solid number rather than trying to guess where we're going to be at is a good choice to go forward. And so I don't see a special session coming up fairly soon.
So, since July 4th, first week of July, if it's going to be after July 1st, it's probably going to be second week, right? Or
right.
Okay,
well, and we'll be getting another update. We're getting updates about every week now, and honestly, it's so dynamic. It's been changing a lot. So you know, to really get a good overall picture of what we're going to be, what deficit is going to look like. I think the more time we have, the better we're going to be in a position to really be able to manage that.
Thank you for that update, Representative Cobb. I want to ask Anne Marie about, let me back up a bit. So we've seen all kinds of stats in the last several days, right? Numbers of cases, infection rates, but statewide, Anne Marie, can you give us a sense of what the hospital capacity is for ICU beds, for ventilators, and when we say capacity, explain to us, what does that mean exactly?
Sure. So hospital capacity refers to the number of licensed beds that a hospital is authorized to operate by Department of Health Services. So, you know, Yuma Regional Valley-wise have a certain number of licensed beds that they currently have. They had the executive order back in March that required hospitals to expand that capacity for any potential patient surge that might result as a part of COVID-19. So hospitals created surge plans to expand their capacity 50% to make sure that we had the necessary beds available to take care of patients in the event of a surge. Now, thankfully, we didn't have the surge that we had prepared for, which is good because we had the stay-at-home order. People took it incredibly seriously. They limited their activity, and we were successful in flattening the curve. So we can do it. And then what we have been tracking, as you referenced, this increasing case rate. We went from about 6% of those tested for COVID-19 who tested positive. Now that's about 15%. And then correspondingly, we've had an increase in both hospitalizations of COVID-19 patients and number of people in the ICU who are COVID positive. So all of those metrics indicate an increased community spread and the need for action. So we were very pleased with the governor's decision yesterday to allow county and city officials to really govern regionally, to look at outbreaks and to be able to tailor their response to their community. So we were very pleased with his action because we can do it. And we saw that in April and May. So we need to kind of continue the vigilance in combating the spread.
Dr. Tranchel in Yuma, what is your capacity right now? And you know, Anne Marie mentioned a surge. You know, what is that surge plan actually looks like for your hospital?
Sure. So we're a 406 bed hospital here in Yuma, and today we have 290 patients in the hospital. Probably about 98 of those are COVID patients. So when you talk about capacity, you can just talk about, you know, the strict difference between what you have in the hospital and your bed availability. But, you know, capacity is also a bit of a dynamic and a fluid situation. If you need to increase your capacity because of a potential surge or a potential catastrophic event, you know, we can throw a pandemic in there too. You know, hospitals are able to utilize, you know, your pre-anesthesia unit, your cath lab. You know, there's a lot of areas in the hospital that you can use to care for patients should the need arise. You know, we're a rural hospital, so we can't really go on diversion. You know, we can't say don't come here because people are going to come anyway. And it's not like we have anybody to offload to. So, you know, the surge line has been a big plus for us, and kudos to the state for putting that together. But we, you know, we planned for surge capacity here on the nursing front and on the physician front, and took the steps early on to, you know, add some additional skills to the nurses that are not necessarily working in the hospital, but had worked in the hospital previously and may now be working in the outpatient environment, and to develop them in such a way in a very short period of time so they could work in a team nursing format. And still, you know, we could still absorb a significant number of patients coming into the hospital without losing any quality or patient safety.
You mentioned you have about 400, a little over 400 beds, and you're close to 300 beds occupied at this point, right? Did I hear you correctly?
Mm-hmm.
Yeah. So in terms of, what about in terms of the ICU beds and then ventilators? Can you give us a picture of, you know, what that looks like for you?
Sure. So we have a 42 bed ICU. Right now, 27 4 patients are in the ICU. 22 of those are COVID patients. 21 of them are on ventilators. So it's so we've got ICU capacity as well. The issue with our COVID patients, and others I believe are experiencing the same thing, is the length of time that they're in the hospital. It's not like they're here for 3 or 4 days, they get better and they go home, as is often the case with multiple disease processes. Many of the COVID patients are in the hospital for weeks at a time. And that's what causes the burden on the system is the length of time that they're there in the hospital. And then you have additional people coming in behind them to fill additional beds. And you're really not vacating the beds that you would normally vacate in say, a pneumonia or an influenza type patient.
So I want to ask Dr. White the same questions. What is the capacity of your hospitals right now? What does your surge plan look like?
So, we're experiencing much as Dr. Trenchell did, through that, we're starting to see increased case rates and increased ICU utilization. We're about the same. We have about 80% of our ICU beds that are full this morning to do that. About half of those are with COVID patients that are at the ICU level of care. Much to what was the same experience around that. Ventilators, we have, about half of the ventilators we have in use today for that, which means we have still half available for those patients that the need were to arise for a variety of medical conditions. We intubate and ventilate patients for a number of reasons, not just COVID-19. So we need to make sure, as Dr. Trenchell mentioned, we're prepared to take care of any patient that will arrive in one of our emergency departments or be transferred in from an outside location. As we talk about capacity, again, physical capacity is that one thing. And I think, as Dr. Trenchell alluded to too, it's really that team that's available to be able to care for patients at the bedside. That's really one of those other resources that we have to be understand. Taking care of a critically ill COVID-19 patient is a special skill set, and it requires a special team to be able to do that. And, again, that's a finite resource that we have within our communities. And I think all of us, as the governor's executive order came in March, went to ways that we could skill up or make sure that we had those workforce or train those workforce to be able to work, collaborate together to make sure we were ready as we see an increased volume of patients. It's been truly remarkable around the teamwork that we've seen of people coming together.
And so let me flesh it out some more. So, we have ICU nurses, ICU staffers, so they know how to intubate, how to ventilate, they know how to work a room, right? But there's a finite number of them, and so not all the staffers, not all the doctors, not all the nurses can do that job. So what you're saying is that you've had to scale that one up and train your staffers so that they can take on that burden and increase the number of folks that you have that can actually take care of a COVID-19 patient.
Right, and exactly that. So, there are basic skills that all healthcare professionals learn as they go through training and things around that. And then there are special additive things around that. So how do you pair an experienced person, to manage some of those higher level of skills where it takes a lot of experience, and offload some of the other tasks to people that may, again, we're able to train and maybe not be as such of those critical tasks, but they're able to maintain not just one, but maybe 2 or 3 patients to be able to do, different parts of the elephant, so to speak, around that.
So I both heard from Dr. Trenchell and Dr. White, and please correct me if I'm wrong, that right now you have capacity insofar as ventilators. Dr. White, you said you're using 50% of them, so you still have 50% to go, and of course everybody's hoping we don't go there. But you do have that. What happens if you actually reach that capacity? Anecdotally, I'm hearing that there are surgery rooms, for example, they could still be converted into COVID-19 beds. But yeah, so let me start with Dr. Trenchell real quick, sir. What happens if you actually reach full capacity with what you have right now?
Sure. So you can use anesthesia, machines as ventilators in an emergency. You can use positive pressure breathing in an emergency, to add additional positive pressure. It's not a ventilator, but it does give positive pressure. So there's other resources, we have, and I think all hospitals have, where they can, if your ventilators, if you've totally exhausted the ventilators that you have, there's other surgery is the place where we would go, frankly, to expand that capacity if it was needed. But, you know, the line really has offered, and I can't speak about that enough because it's really offered a significant way to decompress the hospitals that are getting, you know, sometimes you may get 10 COVID patients at one time that all need admission. If they're all going in the ICU, I could tell you that that's going to be a hard nut to crack at that particular point in time. So the surge line has really helped decompress the facilities. Not so much in a pure capacity perspective, but sometimes it's just, you know, the flow and what you have happening at that particular point in time.
Yeah, go ahead, Dr. White.
You know, and I would absolutely agree with Dr. Trenchell's comments. I mean, we have, you know, as part of those surge plans, you know, we've identified alternative locations to do that, whether it's the operating room that we can use, you know, with the anesthesia machines, you know, Dr. Trenchell mentioned like a cath lab or other places that we do deliver anesthesia. So there's other ways for us to ventilate patients as we need to. And I would agree, you know, having us a statewide network to understand what each other's capacity is in various healthcare delivery locations across the state has really been a tremendous resource to not overwhelm any one location, to make sure that we're able to continue to work collaboratively as healthcare delivery organizations to do that. And again, it's this teamwork mentality that I think, you know, the state of Arizona and all of us that have been utilizing this is really going to help us through this pandemic.
So Representative Cobb, you know, the state put in $50 million, you know, right before you went into I guess a long recess, if you will. And there's also federal money that's come in. Can you briefly talk about, you know, insofar as ICU beds, ventilators, and we'll talk about personal protective equipment here in a little bit, but what has the state done and what should the state do in addition to what it's already done to help the hospitals, to help our workforce that's on the front line?
Well, I think you've heard from both of the doctors here today out of Yuma and out of the metro area. The surge line has been a huge success. Learn from mistakes that were made in New York City, back east, and definitely the collaborative effort that we've had with all of the hospitals has made that easy to make that a successful venture. But also the PPE, the ventilators, any of the materials that the hospitals have needed to be able to take care of the patients, I think we've been ahead of the game. We actually closed up probably a little bit early, I think, on the hospital side, and I would say that my own personal view, but we were overly prepared. And overly prepared means that we don't come into a crisis situation. Now we've got a surge now, which we're utilizing some of the over-preparedness that we had in the past, and we're going forward. Where we're lacking at, I've heard from the hospitals that they're financed from the federal government for 5.5 days for a COVID patient, when a COVID patient may be 15 to 30 days in the hospital. We need to look at that. I think that's something that, we need to kind of fill in the gaps. As we go through this, we're going to learn, and we're not going to be perfect for sure, but filling in the gaps is something that we definitely need to do. The hospital assessment was something that passed right before we went on to break. I think that was something that comes forward. Now, how we utilize that hospital assessment is going to be another step that we might look into as we go forward. Access has been talking to me about maybe doing outpatient as part of the hospital assessments. But I kind of want to get a clear picture of where the hospitals are at the end of the day, what their needs are, and then I think we can make some really good decisions as far as how we can help the hospitals mitigate what kind of losses they've had because of the pandemic.
Can anybody give us an idea, like how much does a ventilator actually cost, and how much does it cost to let's say maintain an ICU bed? And Representative Cobb, you talked about the federal government paying 5.5 days for a COVID-19 patient, and if COVID-19 patient then stays in the ICU or stays in the hospital for 15 days or more, that means, and correct me if I'm wrong, Dr. Trenchell and Dr. White, that means the patient or the hospital takes on that financial burden.
True. And, you know, for us, an ICU day costs anywhere from $5,000 to $7,500 a day. It's not a small amount of money when you talk about the personnel and the equipment and the medications, you know, that you're dealing with. So it's a significant burden. And, you know, if you're not getting reimbursed, there's a circuitous and, you know, way to get additional dollars, but it really never covers your total cost. Because of the way, you know, the payments come through via CMS. And you know, the loss of elective surgery is a loss that's not coming back so quickly, at least for us. You know, our experience has been, we're trying to ramp it back up, but now that we're getting hit with this surge, we're actually peeling back our elective surgery voluntarily in order to maintain the 80% bed capacity, the ICU capacity via the from the governor's executive order. So it's, you know, the financial stresses on the system continue, and hospitals, you know, operate on a very thin margin. I mean, you know, it's a behemoth. I get it, healthcare, but, you know, margins for us are 2 to 3% a year. I mean,
Is that right?
Yeah. I mean, it's, you talk about, you know, the pharmaceutical and the insurance industry. I mean, they don't get out of bed unless they're making 20%, you know. And I can't, you know, the insurers now are, I mean, nobody's doing elective surgery, but everybody's paying, the premiums keep getting paid. You know, we look for some relief from the insurers and they're like, you know, hey, feel really bad for you. Let us know what we can do, but we're not going to do that. So it's been
Luigi, that's something I think that I've been looking at also, is that not only has government needing it stepping up and relieving, but the insurance companies have not stepped up and relieved. Now we did ask Delta Dental to hold harmless some of the dental offices during some of the COVID time, and they stepped up. That was one of the insurance companies that did step up. But just what Dr. Trenchell just said is, you know, no one should be getting rich off a pandemic. And the only industry right now that I could tell you that is probably thriving is the insurance industry. And that's because they're still collecting the premiums, but they're not, there's no utilization. There's no utilization. So they're not using the dollars that they're collecting to put out there for the patients.
And Marie, correct me if I'm wrong. We don't have right now. We don't have a situation, and we don't anticipate one, in which a COVID-19 patient shows up at the emergency room or needs an ICU bed, and that patient is turned away. I don't think that's happened in the United States anywhere in any one of our states. But am I correct?
Absolutely not. Patients, hospitals provide care to patients, you know, whoever comes to their door. There is, hospitals could be on diversion if they are at capacity. And if there are other areas, other hospitals in the area where the patient can be safely diverted to receive care, you know, the system does operate that way as well. But absolutely, hospitals are open 24/7 and take care of anybody who comes to their door. And I think the important part for, you know, we're talking about how hospitals are preparing, you know, to meet this patient surge, that we are getting the adequate staffing, supplies, the space to do so. You know, we're doing everything we can to make sure we can take care of whoever comes to our doors. But we can't do it alone in terms of COVID-19. We need the community to make sure that they are staying safe and that they're not getting sick. You know, it's not enough to say we have room for you in the hospital. We want you to be healthy and not be sick. And that's where this community partnership is really, you know, at a critical point right now. You know, 4th of July is coming up. Families are going to want to be getting together again and to try to get back to life as normal. And we're not there yet. And we have to really maintain our vigilance.
So you mentioned stay safe, stay healthy. All right, tell us exactly how do you, all right, let me back up a bit. We know more about COVID-19 today than we did back in March, right? So we know more about how it's transmitted, et cetera. So to tell our viewers, tell our listeners, like, how do you exactly protect yourself?
Yeah, absolutely. It's what we've been hearing. It's maintain aggressive social distancing when you are with other people, at least 6 feet apart. We have definitive evidence-based studies. Wear a mask. It is one of the most effective things that any of us can do to limit the spread, and everybody wear a mask. Wash your hands, stay home if you're sick, and stay home. Just stay home. Limit your interaction with others. These are the important things we can all do. We did them in April and May, and we were successful. So we can do this again. So know that the hospital community is doing everything we can, but we can't do this one alone.
So wear a mask when you're out in the public. Stay at home as much as you can. Practice social distancing when you're outside. Wash your hands frequently. Those are the things that we've heard again and again, as you mentioned, back in March and April. That strategy worked.
It works.
Yeah. So let's talk about personal protective equipment. There was a point in time when anecdotally I could hear, or I'm hearing, and you're hearing, everybody's hearing that hospitals, their supplies either are running low, were running low, or they're very strident in making sure that the masks, for example, are in fact available for the folks that are taking care of COVID-19 patients, but also for just staffers in the hospital. Where are we with PPE? Let me ask Dr. White.
So, today, we're still something that we watch every day. We monitor our use, we monitor our consumption rates around that, because it changes based on the level and the acuity of the patients that we're seeing to the amount of the PPE that we need to utilize. All hospital and all healthcare delivery organizations have used PPE every day, in the care of our patients. It's just, again, it's to the different levels based on the condition that we're seeing to do that. Today we have adequate supplies, within Valleywise Health, we have adequate supplies to PPE, but we also, watch upstream in the supply chain of where PPE is made, and how we're able to get it into the system so we have it available for use. There is still some constraint within the supply chain around manufacturing of masks, manufacturing of gowns, gloves, of that makes us, continue to monitor this to make sure we're able to get these resources in. We have not yet not been able to get what we need to do that, but it's something that we continue to be vigilant and watch and make sure that we're using it appropriately when we need it.
Let me make sure I understood that. You're saying that right now you have adequate supplies right now, but you're still worried about the supply chain. You're still worried about the manufacturers actually being able to manufacture those masks and getting them delivered to you.
Correct. It's one of those things that we continue to watch, and we continue to be, again, vigilant around, because, many of these areas where these are manufactured and where they're done, were also affected through the pandemic. Manufacturing lines shut down in March and April. They weren't able to get some of the raw materials to make the products that we need to care for patients to do that. And as you heard us earlier, hospital margins are very small. We all relied on just-in-time practices of ordering and supply of that. Not a lot of us had large warehouses where we kept these, this type of equipment on site. We relied on that chain to keep us going forward to do that. So, as we get through this pandemic, I think all of us are going to take a look at that from that to make sure that, we would be ready if this were to ever occur again.
And Dr. Trenchel, is that the same situation you have in Yuma?
Yeah, exactly as Dr. White said. It's the supply chain. Everybody was just putting huge demand on the supply chain early on in the pandemic, and it really caused a shortage. We were fortunate here. One of our local manufacturing firms started manufacturing gowns for us. So, you pay 3-4 times what you pay normally, but you need the gowns for the PPE for your staff. But a lot of ingenious and innovative things came out of it, and people were utilizing their PPE. We found what we could reutilize, what we couldn't reutilize, how to disinfect a mask. So it was, it's pretty significant. The other piece I would say too is, a lot of times you hear about the strategic national stockpile, and, there's this kind of savior that's going to come through, and, we're going to help you with masks and gowns and PPE. And, at least for us, there just wasn't that. There was some support there and relief, and we're very thankful for that. But certainly in the amount that you need, it's not coming from, at least for us, it wasn't coming from the strategic national stockpile. You really have to have a lot of that stuff on your own. And, you know, even hospitals wound up sharing with each other. You know, if you have a little more of this, you share it with somebody else. And, you know, we were the recipients of that. And we were also, you know, some givers in that too. So.
And we have seen people really step up like the last couple of months, right? I mean, like, I know somebody who's actively sewing masks every day and sending some of that to us. I do want to ask Dr. Penchel, does it make a difference if it's a homemade mask vis-a-vis, you know, a manufactured one, at least for the public?
You know, it's still droplet spread, so I think the mask is still is very effective, and I think it's been shown to be that. You know, it's not an N95 mask, obviously, but it will do the job. I'll put it that way.
So, you mentioned the surge plans that you have. You mentioned you know, really training your staffers, your nurses and doctors and other staffers who may not have been working at the ICU units before, but now they're trained. Or so there's, you know, presumably there's you know, you have seen, I don't want to call it an increase in your workforce, but there are more people who can do the job, if you will. But so let me ask you at this point, how are your, and maybe Anne-Marie can give us a sort of a statewide perspective based on what you're hearing from your hospital members, but how is our hospital workforce? Do we have enough? In case we do reach that capacity, we have to put in place our surge plans. Do we have enough workers?
I think a healthcare workforce, it is an issue in terms of being able to make sure that we have the appropriate and adequately trained staff to provide that care. And I believe the state has created a system called ESARVID that would allow other, say, retired clinicians to come back online and to volunteer through this system where they can get credentialed and get you know, the required background checks, and then to be deployed, you know, in their hospital, or if there was an alternate care site that was created, that they could provide care there. So I think the state has been thinking about and addressing ways in which we can expand our already currently licensed capacity. I know some of the regulatory boards fast-tracked some of their application process for students to come back, for students to get expedited in the process. So we didn't have the delay that sometimes we do with board certification. So, so it is an issue. And I think the state is being creative in how to make sure those regulatory burdens and hurdles are loosened so that we can really get the healthcare providers where they need to be.
Representative Cobb, I want to ask you, what kinds of conversations are you hearing in terms of, you know, what Anne-Marie has mentioned, which is trying to expedite this licensing processes, and, you know, in what areas you think the state can help? You know, there's a very truncated time frame that we're looking at, right? If there's a surge and we're at full capacity and there's a surge, you know, that's a very short time frame. But I want to see what you're hearing from folks and what and where else the state might be able to come in and help.
Well, if you've looked at what we've done, Luigi, in the past 4 years, you could see that we've decreased regulations and licensing, and that's reciprocity was one of those things last year. Licensing across borders is something that we've been working on, and thank God we had that. I mean, that is one of the things that has brought forward some relief, is being able to have doctors come from other areas and come into the areas that are needed, which is part of the surge capacity that we're looking at. That has been something we've been looking at for a long time. So I think that we're already, again, ahead of the game on some of these issues. But just what Anne-Marie was just saying is some of the licensing boards were able to fast track, decrease liability for people coming in that were working during the pandemic. I think that we still need a lot of work to do in the liability area. If anything that the legislature, I think, needs to work on right now is working on the liability for the hospitals and the providers that are coming into the hospitals.
So when you mention liability, you're referring to you know, trying to inoculate, maybe protect you know, businesses, hospitals, you know, clinics, effectively from getting sued, for example, on the charge that, you know, a customer walks into a restaurant or any other business, 5 days later tests positive for COVID-19 and then, sues that facility, right? That's what you're talking about.
Yes, that's exactly right. So the liability is not just for the hospitals, but I mean, we're looking at the liability piece for the schools. We're also looking at it for small businesses. When we're talking about liability, it's from the gross negligence. We have to also look at the providers and how they're providing the care. We're all in this as something that's new, that we're, the standard of care is, there's not a book out there for the standard of care like there is for other issues. So we want to be able to say, we're giving you the best care. We don't want to give them an out if they don't provide a good standard of care, but we also want to give them an out if there's not gross negligence. You could see last year we had the ADA issue where there was some,
it has to do with the science, right?
Yeah, the predator lawyers that came out and said, we're going to sue everybody and hopefully we'll get some relief, or we'll just settle out of court instead of going to court. I could see that happening if we don't have a liability plan in place.
So I want to touch on testing just real quick. Right now, we have, as of yesterday, I've looked at some of the data. We've done more than 500,000 tests. That's roughly 7% of the state population. And I want to ask Dr. White and Dr. Trenchel, ideally, and when I say the word ideally, I use it very carefully. What is the testing level that we should be at? As I mentioned right now, it looks like we're at 7% of the population. Where should that be? And by the way, based on what you're seeing in your hospitals, where are we at with testing? I'm sorry, Dr. White, go ahead, sir.
I think ideally we would, where we are today is, early on we were worried about reagents and we were worrying about testing supplies and things early on in the pandemic to be able to test those that were symptomatic and worried around having COVID-19 disease. That has certainly improved to the point that we're able to test, anybody that we're suspicious from a supply perspective around this. We would like to attest and identify those with symptoms because it helps us, again, around being able to properly instruct the community and the patient of what to do to reduce the transmission and how to isolate and quarantine, again, to help us reduce the spread and start to flatten the curve around that. Our testing capacity throughout the state has continued to improve, here over the last, over the last 6 weeks to do that, which has helped us be available to be able to provide that information around that.
Dr. Trenchel, we've heard anecdotally or some news stories from friends, they want to go get tested. At one point there were waiting lines, right? And it seems like the waiting lines have gotten shorter and shorter. So that really is a step in the right direction. But we've heard when they've gotten a test, they've had to wait, several days, sometimes 1 week, sometimes a little more than a week. In theory, if you're positive all that time that you're waiting for your test and you're going around, then you have potentially been exposing others to COVID-19. What are you seeing on that front, sir? Is this what's, can you validate that's, the number of days and the concern over not getting the results right away?
Sure. So, and there's different mechanisms for that. We have, if you have the right machine, it'll give you results in an hour. We get usually a 6-hour turnaround for some of our testing. But I think the key here is, everybody wants to be tested, and I get that. But, we know we have community spread. We know there's community spread. So you have to assume if you're ill, you are most likely ill with COVID, you need to self-quarantine, and you need to be out of the population. So whether you get tested or not, if you're displaying symptoms, you need to self-quarantine. And that's really what it comes down to. You know, we can test, but that test may be negative today. It may be positive tomorrow. You know, the best we have is to know that we have community spread, and to self-quarantine if you're ill. Certainly stay home if you're ill. Stay out of the workforce for sure if you're ill. Self-quarantine from your family. And if you're not displaying symptoms, I don't know if the science is out. Dr. White could probably answer it better than me if there's asymptomatic spread, but that's really the key. But, you know, we all have to assume, you know, wear your masks, wash your hands, and do that. But the testing, you know, the testing's important to do. But at this point, you know, if we did another, you know, 500,000 people, maybe it shows us that we have more positives than not. I don't know, but whether we do more testing or not, we still have to assume there's community spread. If you're symptomatic, stay home and wear your masks.
A lot of this falls on, I'm sorry, Anne-Marie, you were going to say something.
You know, I was going to kind of add on to that. It's also important that we make sure those people living in congregate settings, you know, people who are in facilities, long-term care, that we're testing both the healthcare workers in those settings and the patients living there, because those are really the at-risk, vulnerable populations. Those are the ones who are, you know, typically over 65 with comorbid conditions, and those are really the at-risk patients. So we have to make sure there's adequate testing, widespread testing in those areas. And then for some hospitals have reported that there has been lack of testing supplies, reagents, mediums, lack of a turnaround time if they didn't have the machine in their hospital. And that impacts capacity because you're unable to discharge patients. So we just have to make sure that the testing is available for those most crucial areas, hospitals and those living in congregate settings. I don't know that we need the drive-by testing or the worried well to the extent we really need it for, I mean, if we had a multitude of testing, we could certainly test everybody, like some countries have done, but we do have limited supply right now, so make sure it goes to who needs it.
So go ahead, Dr. White. Yep.
You know, and I think Anne-Marie has a very good point, you know, around the different ways that testing does occur and the different types of tests that are in production used today. You know, testing for COVID-19 disease did not exist in January. So all of these tests have really been developed, manufactured, and come to market very quickly around that. So there's lots of different things that are available. So we all have to, as healthcare delivery systems and things, evaluate, you know, what does a positive test mean? What does a negative test mean? You know, how good are the tests that we're using? You know, they've continued to improve, again, all the way through this pandemic to do that. But the time that it takes for us to get a result varies on, as Dr. Trenchel mentioned, the equipment that we use, the type of reagents that we use, and there's such a variety across the United States around that. That's why we see such a variation of these testing times. If a test takes, 14 hours to run and a lab got, 1,000 tests to run that day, they don't have the instruments to process all of those in that initial 14 hours. They have to stagger them. So, the results then will come out in a staggered manner. So from that, those are some of the challenges that we continue to work through on this testing issue.
So we talked about the potential for a surge and the surge hospital plans, which would entail, among other things, converting some of your surgery beds into, COVID-19 beds. I anticipate if that happens, it's going to be a financial burden to the hospitals, because then you're not doing elective surgeries, you're not getting that revenue. And we are still in a situation in which a lot of people don't really want to venture outside. They might have put on hold, the healthcare that they needed, but they're not just doing that right now. So there's that revenue from the hospitals as well that's not being realized, as it had been realized before. You're looking at a 2-3% margin. Representative Cobb, you mentioned the hospital assessment that was just passed, before the recess. You talked about, probably filling the gap within that, the funding gap, right? The feds will pay for 5.5 days of COVID-19 stay. But, if the patient stays 15 days or more, that's a problem. Anne-Marie, I want to ask you, where else can the state, come in and help? What else can the state do? And I guess to Representative Cobb as well. But let me start with Anne-Marie.
Sure. So, I think the financial viability and the strength of hospitals is so crucial. And I really want to recognize that we realize that all of Arizona, all of our businesses, communities, healthcare, everybody has been affected by this economically. It's been devastating for so many of us. So I think, hospitals certainly recognize the impact of our other community partners. But there is a unique and central role that healthcare and hospitals play in this response, that we need to make sure financial infrastructure is there to support hospitals so that we can continue to meet our payroll, to have our doors open and to not close. Which for some hospitals, there are some financially vulnerable hospitals in Arizona. So we just have to make sure that these crucial services and these really cornerstones of the community can continue to be strong, because it's essential in this pandemic that we're able to do so. And I think one important sort of policy consideration is, as the economy has downturned during this time, that it's important that that hospitals really do have those financial resources. We do get some from the federal government in terms of stability, but that there's going to be a payer mix shift. There's going to be more unemployment, certainly, and we've seen that in the numbers, and that will transition the payer mix for hospitals from a commercial payer, which is typically, and Dr. Trenchel can correct me, or he really experiences this every day. That's a really important source of margin for hospitals. They will transition to access rates. Now, we were able to get, the hospital assessment past this past legislative session. Honestly, I don't know where our industry would be if we hadn't done so. That's so crucial. And thank you, Representative Cobb, for leading that effort. We will need every dollar of that to sustain this healthcare infrastructure. But there's going to be a significant shift from commercial to access enrollment. And then with that is an increase in the assessment that hospitals pay that fund a good part of that. So there's a lot of shifting pieces here, and we just need to have the support of the state to really keep hospitals financially stable so that we can continue to provide those essential services.
Representative Cobb, you're facing dwindling revenue, right? Not only the hospitals are going to ask for state support, and the schools are probably going to get hammered if you see a drop in the number of students that physically show up in schools. There are industries that are hurting as well. How do you navigate through all of these?
Well, it's I can't say it's easy, but it's a balancing act. We have to look at all aspects of it. This is our front line. The hospitals are our front line. So that's probably where we're looking at first, is where we have to take care of the patients and what we can help the hospitals with. Data is important. I can't stress that enough. When I come together and I want to look at just what you said, lower enrollments in the schools, I need the data. I need the data for the payer shift from the hospitals. I need those things to happen so I could see where we need to dynamically move. And it is a moving target at all times. And we have to balance it with all the other industries that we have out there. It is going to be a difficult year. I don't even say it's going to be a difficult year. It's going to be a difficult 2 or 3 years. We have to come in out of this, not just looking at it as a 3-month pandemic, but it's going to be a year-long or 2-year-long pandemic, and the recovery is going to be that. We may get a quick recovery once everything starts, heating up, but it's going to have long-term effects.
And at this point, we have a lot of questions from our viewers and listeners. We'll try to get to as many of them as possible. So here's one question from Mary. Is there a coordinated effort across the state to test the most vulnerable populations and mitigate the risk of further infections? Anne-Marie, you want to take a stab at this question?
Is there a coordinated so I believe Governor Ducey did have an executive order with respect to prioritizing those living in congregate settings with prisons and long-term care, skilled nursing. Was nodding his head.
He did.
Yes.
Yep. Dr. White or Dr. Trenchell, here's a question I think you can answer. How are the hospitals preparing for the fall when our seasonal residents return? You know, we do have a large, I call them migratory population. You know, they're not necessarily here right now, but they'll be here in the fall and in the winter.
I think, all the work that we've done here, in the preceding months around creating these plans, around creating these surge plans, is anticipating, some of that volume, returning, or some of the, number of citizens and folks that live in Arizona returning in the fall. So we're making sure that we have that available. I think all of us are working to see how we can augment our teams and our staff by making sure that we're able to hire and get folks, onboarded here during the summer that are available. So we're ready if we see some of that increased volume.
Dr. Trenchell, here's a question I think you may be able to answer. What do you think of managing transboundary spread? We saw this earlier in which, some states are saying, look, if you're from this state and it's a hot spot, we'll probably limit your travel. What do you make of that?
So it's, we limited, we didn't limit, but there was the quarantine, I think, in effect for Arizona, if you came from hotspots. Us here is we're in a unique situation because we are close to the border, an international border, and we're also close to California. California, Imperial County, east of San Diego has had a pretty significant uptick in their cases too. We haven't seen people coming over the state border, here for care. Even though they went on diversion, they went west to San Diego. But, hospitals are going to manage whatever comes to their front door. You could say whatever you want and you can try and limit whatever you want. But if there's a person there that needs care, you're going to deliver that care no matter what. So, you're just going to have to deal with it.
Dr. White, so here's a question that I think you can answer from John. Most healthcare facilities across the state instituted partial or complete no visitor policies during the pandemic, but the Health and Human Services, I think the Federal Health and Human Services recently issued a ruling requiring that individuals with disabilities, especially those with cognitive or communication challenges, be granted accommodations such as in-person support while hospitalized. In the absence of a statewide guidance, and I don't know if there's an absence of a statewide guidance, what are hospitals doing to ensure patients who require these accommodations are being provided to them?
I think all of us, as we put our, policies in place to limit the visitors, to, decrease the chance that somebody could bring this into any of our patient populations, recognize the fact that we were going to admit patients that needed support, either be, they're at end of life from this. They're younger patients, our pediatric patient population, and the vulnerable patient population that's kind of described in the question there. I think each of us make those accommodations based on the absolute needs of the patient. I don't think any organization has a hard and fast rule. If somebody was, in one of those situations, certainly needed to have that bedside support from a family member or another individual to assist with communication around that would be denied. I certainly know that I always just speak from our experience here at Valleywise is, as we've had those patients, we've made those exceptions. We've screened those individuals that are coming in to, to make sure that we're protecting the patients and the staff, to make sure that they are COVID free to the best of our ability to be able to have those people here to help, with that particular patient.
So, and I don't know how accurate this one is, but we've heard, or there are some anecdotal stories we've heard that maybe that Surgeline has been giving out incorrect info about which hospitals have the capacity or not. Do you want to weigh into this one insofar as the accuracy of the data that's being gathered or being sent? Maybe Anne-Marie can answer this question.
So are you talking with regards to the surge line?
Yeah, I'm talking in regards to the surge line. There have been some questions, if you will, about the accuracy of the data.
We have not heard that. We've really heard positive feedback from hospitals and being able to, what was reflected in the conversation today that, patients are getting the level of care that they need regardless of where they are in Arizona, and that there's this coordinated effort among hospitals to make sure that happens. So I think it's a really good example of the state leading a well-coordinated healthcare delivery system in this time. And we stood it up. DHS stood that up really relatively quickly. So if there are, I'm sure there are kinks to be worked out in the system, but I think fundamentally it's the right platform and the right direction for us to go. And I'm sure Dr. Trenchel or Dr. White have real experience in using that.
So one quick question, I guess, to both doctors. What do you think of the schools reopening and some of them reopen in July? I've had to struggle over this one because my son's school gave us options, right? You can send your kid to school physically, you can do kind of a hybrid, and you can do virtually. To parents like me, what's your suggestion, sir? Both of you, Dr. White and Dr. Trenchel.
Sure. So I'll take this first. That's a challenge. I don't think there's any easy answer. I do think, though, however, we have not seen a lot of pediatric cases, and I don't know what the data shows regarding, transmission for pediatrics or younger. Certainly the data that we've seen here is mostly older individuals with comorbidities. We've seen are impacted the most from a health perspective. I'll give you a circuitous answer, then I'll give you my short answer would be, I think school should start. That's my short answer. Thank
you for that. Dr. White, your thoughts, sir?
Certainly we've seen pediatric patients that have tested for COVID-19 disease. Certainly it's been more on the mild side. As Dr. Trenchel noted, we haven't seen a severe need of hospitalization and things, for the pediatric population to do that. We still don't know around that spread, of how the children may transmit it to the adults transmit it to the children, and vice versa, and what the impact of that is. Certainly, we want to see education resume. I think this is an important thing for our children to go back to school, to be able to, facilitate learning and facilitate their growth and development as they need to. So it is going to be something that we're going to face. I think those questions are going to answer as we bring children back together, in the fall.
Oh, I do have I'm sorry, go ahead.
I do have a data point for you on this. 9% of cases require hospitalization. And of that, it's about 2/3 are over 65 and about 1/3 are between 20 and 44. So that really shows, in terms of hospitalization of patients, you're not really seeing, that goes what Dr. White was saying in terms of the pediatric population, but that's what it's reflected in terms of the statewide data and who needs hospitalization.
So I do have that. I think we're almost out of time. I have one question for Dr. Cobb. Dr. Cobb, you're a doctor, ma'am. If there's a need for any one of the hospitals to get you back in service to help out, I wonder what your thoughts are.
I am a dentist, so I do have a few dental offices that have asked, for me to help out. And honestly, our dental community did help the hospitals out when we needed PPE and those kind of things. And definitely I would be there to be of any kind of volunteer service. I've done volunteer service over the years, and this is not unusual for me to do. So I would be glad to be in there with you guys.
And so I do want to mention that the Flynn Foundation created a mask cap campaign. And so there is a very strong emphasis by I think at this point everybody to wear a mask in public. I want to thank Anne-Marie, Representative Cobb, Dr. White, Dr. Trenchel for spending your morning with us. To our audience and to our viewers and our listeners, thank you for also spending the morning with us. I'm very thankful that we can have this discussion, and I think we went through a lot of questions. And I appreciate the time. I hope that we're not going to have to impose your surge plans. And I think everybody hopes that, we're able to get really manage this pandemic as well. And to everybody again, and to the Arizona Health Hospital and Healthcare Association, I want to thank you for sponsoring this morning scoop. Bye for now, and you have a wonderful rest of your day.
Thank you.
Thank you, Luigi.
Thank you.
Thank you.
Thank you.
Thank you. Bye, everybody.
Bye-bye.
Bye.